हाय एवरीवन। आज के टॉपिक में वी आर गोइंग टू डिस्कस अबाउट अपर लिम ट्रॉमा। अपर लिम ऑल्दो इज़ अ वेरी वास्ट टॉपिक, बट हम सीक्वेंशली एक एक वीडियो में डिवाइड करके विल गो स्लो एंड स्लोली एंड कवर ऑल द जॉइंट्स. In today's topic, we are going to cover shoulder joint as well as the humerus fractures. So, the first topic, that is the anatomy of the shoulder joint. So, in anatomy, we know ये है हमारी scapula. This is the scapula bone. This is the clavicle. This is the humerus. So the humerus is articulating with the scapula at the glenoid of the scapula, and it forms the glenohumeral joint. We also have articulations of the scapula at the acromion process. So this is the acromion process, and this another process anteriorly is the coracoid process. So the ligamentous attachments are present here. The joint found between the acromion and the clavicle is called the AC joint or the acromoclavicular joint. Similarly, we also have attachments between the coracoid and the clavicle. So primarily यहाँ पर हमारे पास दो ligaments हैं. So अगर हम देखें, we have spoken about the AC joint. So here now we have the CC joint, that is coracoclavicular joint, and इसमें also we have conoid and trapezoid. अब इसको याद करने का तरीका क्या है? C and central, दोनों C. तो conoid is placed centrally. Central means more medial. So this is the conoid and this is the trapezoid. Okay, so we have AC joint, CC joint. We have another ligamentous attachment that is present between the coracoid and the acromion. That is called the CA joint. That is coracoacromion joint. So another thing about the anatomy part that most of the students confuse is about the anatomical versus surgical neck. इसको याद करने का बहुत इजी फंडा ये है कि ए होता है अल्फ़ाबेट सीरीज़ का पहला लेटर, सो ए कम्स फर्स्ट. सो द एनाटॉमिकल नेक कम्स ऊपर. ऊपर मतलब मोर प्रॉक्सिमल. सो यू हैव द एनाटॉमिकल नेक ऑफ द ह्यूमरस हेयर followed by the surgical neck somewhere around here. Okay, so this is the anatomical neck and we have the surgical neck. So अब क्वेश्चन उठता है, why is the shoulder an inherently unstable joint? So the reasons primarily are the size difference. So if you look at this example, this is a tee of a golf ball and a golf ball placed on top of it. हम देख सकते हैं कि there is a massive size difference between the articulating part of the tee with the ball. Same is the story with the shoulder joint. The glenoid के साथ जितने हमारा humeral head articulate कर रहा है, that part is very very small, making it inherently unstable joint. Second reason is the capsular laxity or the capsular attachment surrounding the humeral head. It becomes lax on movements. That is another reason. The third and final reason is the shoulder joint is the only joint in the body that has the maximum range of motion. शोल्डर जॉइंट में सबसे ज़्यादा रेंज ऑफ मोशन है, और जहाँ मोशन ज़्यादा है द चांसेस ऑफ इट बीइंग मोर अनस्टेबल इज द मैक्सिमम. ओके, सो मूविंग अहेड वी आर टॉकिंग अबाउट द रोटेटर इंटरवल नाउ. ये एक एमसीक्यू क्वेश्चन है जो काफ़ी बारी देखा है पेपर्स में भी पहले. रोटेटर इंटरवल, वी ओनली हैव टू नो दिस दैट इट इज़ बिटवीन सुप्रास्पाइनेटस एंड सबस्कैपुलारिस. ओके, ये इंटरवल सुप्रास्पाइनेटस और सबस्कैप के बीच में आता है. अब यहाँ से बात अराइज करती है कि व्हाट इज़ रोटेटर कफ. रोटेटर कफ प्राइमरीली हैज़ दीज 4 मसल्स ग्रुप्स विच इज़, जो हम सिट्स के मेमोनिक्स से याद किया हुआ है हम लोगों ने. सो सिट्स में फर्स्ट इज सुप्रास्पाइनेटस, इंफ्रास्पाइनेटस, टीरीज माइनर, नॉट मेजर, माइनर, एंड सबस्कैपुलारिस. अब इसमें देखें, जो सिट वाला पार्ट है दैट अटैचेस ओवर द ग्रेटर ट्यूबरोसिटी, दैट इज द GT, whereas the subscapularis attaches over the lesser tuberosity. ओके अब हम चलते हैं टूवर्ड्स क्लैविकल फ्रैक्चर. दैट इज अ वेरी कॉमन फ्रैक्चर सीन इन आर ओपीडीज एंड बहुत ज़्यादा कॉमन है एंड इसकी ट्रीटमेंट प्रोटोकॉल इज़ काफ़ी इंपॉर्टेंट फ्रॉम यूजी पॉइंट ऑफ पर्सपेक्टिव. So clavicle fractures usually happen with a foosh injury. So foosh is basically fall over outstretched hand. ठीक है. So the fall over outstretched hand causes the force to get concentrated over a clavicle and ultimately we get a clavicle fracture. So like any fracture we have pain, swelling and crepitus. So what is crepitus? If you hold the bony attachment, if you hold the bone where the fracture is there and move it, you get some coarse gritty sensation that is called crepitus. Also कोई भी fracture हो, we must look for the distal neurovascular deficit since a major blood vessels, subclavian vessels as well as brachial plexus are present near the clavicle side. Okay. इस फोटो में if we look closely we can see that this is the medial or also we can call the proximal part of the fracture and this is the lateral or the distal part of the fracture. Okay, so this is the lateral or distal and this is the medial and the proximal part. So depending on the attachment of the muscles to these parts, the displacements are there. So for proximal attachment, we have sternocleidomastoid, that are the strap muscles, the neck muscles are the present here. Proximal fragment को अपनी तरफ ऊपर खींच लेते हैं, that is they pull them proximally. Whereas the distal fragment, यहाँ पर हमारी attachment आ जाती है pec की, as well as we have the weight of the arm. So it goes distally as well as medially. क्योंकि pec pushes it medially and the weight of the limb pushes it distally. So this is the routine displacement that we get in mid-shaft clavicle fractures, which is the most common site of clavicle fractures. Diagnose कैसे करेंगे? Sorry. So for diagnosis, we move on to the X-ray. इसमें basically we can see the same thing, the displacements of the proximal and the distal fragment. The treatment protocol is very important. That OPD में काफ़ी दफ़ा देखा है कि a lot of even the topmost surgeons miss this. They either give just an arm pouch or just a figure of 8 bandage. The combination of both of them is needed. Why? आर्म पाउच किसके लिए? आर्म की सपोर्ट लगा दी, ये सुपीरियर इंफीरियर डिस्प्लेसमेंट ऑफ द फ्रैक्चर फ्रैगमेंट रोकता है. ओके, बट वी स्टिल हैव द एंटीरियर पोस्टीरियर और द एपी ट्रांसलेशन ऑफ द फ्रैगमेंट, उसको रोकने के लिए वी हैव द फिगर ऑफ 8 स्ट्रैपिंग. ठीक है, सो ये दोनों देनी है. यूजली रूटीन प्रोटोकॉल यही रहती है फॉर मिड शाफ्ट फ्रैक्चर्स. आफ्टर दैट ऑलमोस्ट 2 से 3 हफ्ते का वी गिव द पेशेंट आर्म पाउच एंड फिगर ऑफ 8. स्टार्ट विद जेंटल रेंज ऑफ मोशन एक्सरसाइजेस एंड दे यूनाइट ब्यूटिफुली. When do we need to operate clavicle fractures? The question arises. If we have a severely displaced fracture, if there is a distal neurovascular deficit, okay, or it's a cosmetic issue. For अब कई बारी severe displacement हो and we treat it conservatively, we often get malunion or non-union. Non-union की propensity low है, but we might get malunion certain amount of times, so we need to operate them. And the patient might ultimately develop a cosmetic deformity, which is not so pleasant to see. Distal neurovascular deficit, we have subclavian and brachial plexus around it. And again, agar we do not encourage the range of motion, the person can land up into stiffness of the joint. Okay, so that is pretty much about the clavicle fractures. Moving on to shoulder dislocation, which is an extremely important topic from UG as well as PG perspective. काफ़ी बारी आपके प्रॉफ एग्जाम्स में भी शोल्डर डिसलोकेशन पे लॉन्ग नोट आ जाता है. इवन इन नीट यू गेट मेनी क्वेश्चंस रिलेटेड टू शोल्डर डिसलोकेशन. सो इट इज़ द मोस्ट कॉमनली जॉइंट दैट गेट्स डिसलोकेटेड. द रीज़न वी हैव ऑलरेडी डिस्कस्ड व्हाई, इट बीइंग अ ग्रॉसली अनस्टेबल जॉइंट, राइट. सो वी हैव टू रिमेंबर, शोल्डर में द एंटीरियर डिसलोकेशन इज मच कॉमन दैन द पोस्टीरियर डिसलोकेशन. हिप में इट इज़ ऑपोजिट, posterior is more common than anterior. So in hip, posterior is more common than hip. And hip में अगर हम भी आते हैं, sorry, anterior. And to remember, the characteristic attitude in posterior dislocation of hip, we get fadir, that is flexion, adduction and internal rotation, and anterior में we get faber, that is flexion, abduction and external rotation of the limb. Okay, ये subsequently हम lower limb trauma में discuss करेंगे, but moving on, post dislocation we often get lot of instability. It can be unidirectional instability, bidirectional or multidirectional. So the mechanism of injury more or less remains the same. It is a whoosh injury, that is the fall over outstretched hand, with shoulder abducted as well as externally rotated. Okay, so this is the most common, the mechanism by which we get anterior shoulder dislocation. In posterior shoulder dislocation, the most common etiology remains epilepsy, electric shock, and posterior dislocation is often missed because the X-ray appears more or less normal. So this is an X-ray of posterior dislocation. But if you look closely, we have this characteristic light bulb sign present here. Okay, but it can be routinely missed in just plain X-ray films, and we might need to get a CT scan. There is also loss of external rotation in a posterior shoulder dislocation. So अब हम classify करेंगे, this is the classification of anterior shoulder dislocation. बहुत basic है, सब coracoid, मतलब coracoid के नीचे. So this is our coracoid process and इसके नीचे हमारा humeral head आ गया है. So this is subcoracoid. Similarly, glenoid के नीचे तो subglenoid, clavicle के नीचे subclav and thorax में चला गया तो intrathoracic. Okay? अब जो आ रहा है बहुत ही ज़्यादा कॉमनली आस्क्ड क्वेश्चन, बैंकार्ट है क्या? बैंकार्ट. ओके, सो व्हाट इज बैंकार्ट? बेसिकली repeated shoulder dislocation causes the anterior inferior labrum to get damaged. So we are viewing glenoid from the side in this photo and we can see the anterior inferior surface of the glenoid labrum gets damaged. Along with this, the anterior inferior periosteum also gets damaged. And if at all due to repeated recurrent episodes, we get a bony piece along with this, it is called a bony Bankart. Okay, so Bankart is the anterior inferior labrum that gets damaged. We also have this characteristic Hill-Sachs lesion, which is present over the posterior lateral quadrant of the humerus. We get a depression. So assume that this is our shoulder joint. ये dislocate हुआ यहाँ पर, वापस relocate के time the posterior lateral aspect of the humeral head hits the surface of the glenoid. This repeated hitting causes a depression over the posterior lateral aspect of the head of the humerus. Okay, so this is the Hill-Sachs lesion. Repeated जिनको recurrent shoulder dislocation होती है, Hill-Sachs plain X-ray में आपको दिख जाएगा. Bankart के लिए you often need a MRI until and unless it's a bony Bankart, but for Hill-Sachs X-ray में हमें दिख जाता है. So how does a patient present? Clinical या फिर OPD में presentation क्या रहती है जिससे आप suspect कर सकते हो कि the patient has a shoulder dislocation, anterior shoulder dislocation. So the shoulder is abducted with elbow supported with opposite hand. Shoulder abducted and supported with opposite hand. So this is the characteristic presentation. Since the shoulder is dislocated, our acromion becomes prominent. The normal original contour of the shoulder is lost. The arm is in slight abduction. Elbow flex करके रखी हुई है and दूसरे arm से support किया हुआ है. अब मूव करते हैं कि चलो ये तो बहुत बेसिक प्रेजेंटेशन हो गई. How to ascertain it clinically? So these are certain tests, certain characteristic tests that help us identify shoulder dislocation. So in this picture you can see ये वाला आदमी अपने इस हाथ से अपने शोल्डर को टच कर रहा है. That is normal, we all can do it. But if the person has a dislocated shoulder, he is unable to touch the opposite shoulder. This is called Duga's test. Okay. Now moving on to the Hamilton ruler test. So इसमें in a normal shoulder अगर हम यहाँ से scale लगाए, that is from the lateral edge of the acromion along the arm, we cannot touch it at the same time to the lateral epicondyle or the lateral surface of the elbow because of the normal contour of the shoulder. But in case of shoulder dislocation, this contour is lost and we are able to place a scale from this point to this point. So this is the Hamilton rural test. The third we have is the Callaway's test. ये usually book में mention नहीं होता, but in this there is an increase in the axillary circumference of the dislocated side. Okay, so this is the Callaway's test. So how do you now the question arises, how do you reduce an acute dislocation? बहुत सारे method है, but the most widely accepted method is the Kocher's maneuver. Okay, so in this इसका mnemonic है बहुत easy याद रखने का, TEAM, TEAM. T से ट्रैक्शन, E से एक्सटर्नल रोटेशन, A से एडिडक्शन और M से मीडियल या फिर इंटरनल रोटेशन. सो हाउ डू वी डू इट? सपोज दिस शोल्डर इज डिसलोकेटेड, ट्रैक्शन, external rotation, adduction, and medial or internal rotation. Okay, so this is the Cocker's technique to reduce a shoulder. Historically, we also had the Stimson's maneuver, जिसमें with the help of gravity, a weight was suspended from the wrist, and ultimately the whole point of suspending a weight from extremity is so that the muscles ultimately fatigue and the shoulder automatically relocates. 10 से 15 मिनट से ज़्यादा टाइम लगता था यूजली इस चीज़ में, एंड आजकल वी डू नॉट प्रैक्टिस दिस. दिस इज़ ऑल्सो एन ओल्ड मेथड, हिपोक्रेट्स का मेथड था. इसमें एज यू कैन सी द पर्सन पुट्स हिज लेग इन द एक्सिला ऑफ द पेशेंट. रिब फ्रैक्चर वगैरह भी हो सकते थे, बाकी कॉम्प्लिकेशंस हो सकती थी, काफ़ी ज़्यादा पेनफुल और थोड़ा उस टाइप का मेथड था. सो ये भी आजकल यूज़ नहीं होता, बट कन्वेंशनली स्टिनसन्स as well as Hippocrates were also methods which were used. So the complications of shoulder dislocation are axillary nerve. So we have to check axillary nerve, which we can check by two methods. First is you can ask the patient to abduct, but since it's acute episode है, patient के लिए painful है, तो आप movement नहीं कराओगे of course patient से. So second चीज़ जो रहती है जिससे आप check करोगे, आप over the outer lateral aspect of the deltoid sensations check करोगे. If they are present, the chances of axillary nerve being injured are low. Okay, और late complications क्या हो सकती हैं? Redislocation. Okay, so moving on to the treatment part, we learnt about the bank cut, that is the damage to the anterior inferior part of the labrum of the glenoid. So here we repair the bank cut. So in this picture you can see this metallic device. This is called an arthroscope, and these objects present over the labral part are called the suture anchors. So basically in this we use an arthroscope to surgically repair the bank tear using suture anchors. So this is an arthroscopic bank repair. Okay, so the second procedure is called the Bristow's procedure. In Bristow, so this is again we are viewing the glenoid, हम साइड से देख रहे हैं glenoid को. यहाँ पर we have the acromion process and this is the coracoid process. So in Bristow हम coracoid की osteotomy कर देते हैं, and along with the osteotomy हम जो coracoid पे जो muscles attached है उनको भी उठा के we screw it along the edge of the glenoid. So basically in this procedure, now we are augmenting the bony loss as well as we are providing a dynamic sling support to the damaged labrum. So side question is, what are the muscle attachments over the coracoid process? So it can be remembered by this mnemonic PCB. This is physics, chemistry, physics, chemistry and biology हमने याद किया था. So PCB, so P से we have pec minor, C से we have coracobrachialis, and B से हमारे पास है biceps. So PCB, mnemonic for attachment of muscles over the coracoid process. Moving on, we have the Porty-Platt procedure, where यहाँ पर देखिए, यहाँ पर we have a double-breasted coat. So similarly here we do double breasting of subscapularis. Okay. So double bracing of subscapularis is done here. Ultimately, this double breasting leads to us preventing, what does it prevent? External rotation plus abduction. Okay, so external rotation and abduction is prevented. So moving on to the next topic, that is the surgical neck of humerus fractures. Basically, proximal humerus fractures में we are going towards this. Elderly females में more common होता है because of the osteoporosis subsequent to the menopause that causes decrease in the bone mineral density. And इसकी classification, this is the Neer's classification for proximal humerus fractures. इसमें basically we divided it into 2 part, 3 part और 4 part depending upon the कौन से part में fracture है. Anatomical neck, surgical neck, GT, LT or fracture dislocation that could be anterior or posterior. So how do you manage it? The treatment protocol remains, we proceed with conservative management, that is with sling, in case of patients those who are PAC unfit or with increased medical comorbidities, जो basically are not fit for surgical procedures. Okay. Operative में we have this percutaneous wiring. The first example is a percutaneous wiring. Mostly we use it in females for stapler fractures. इसमें हम transcutaneous, that is a percutaneous, we put in K-wires. This second is a phyllos or a proximal humerus interlock system. So this is also treatment protocol. And यहाँ पर हमारे पास है TBW or the tension band wire. So in this basically the tensile forces are changed into compressive forces. So in this case we have shoulder arthroplasty. This is the reverse shoulder or RSA जिसको हम बोलते हैं, reverse shoulder. So these are the treatment modalities for proximal humerus fractures. Specifically if we look, so in reverse shoulder we are reversing the anatomy. So we have a glenosphere in place of the original glenoid and we have a humeral stem as well as a humeral cap articulating. Okay. तो अब हम चलते हैं shaft of humerus fractures में. Again twisting and bending force के कारण we get this injury. Fouche injury again, it can be either due to a direct injury as well. The thing we have to, the basic anatomy of humerus is such that in the upper half of the humerus it is cylindrical and begins to flatten in the AP direction as we go downwards. अब यहाँ पर आप देख रहे हो जो मैंने रेड से लेबल किया, दैट इज बेसिकली द डेल्टॉइड ट्यूबरोसिटी. यहाँ पर आके हमारा डेल्टॉइड अटैच हो रहा है एंड अल्टीमेटली this is the reason for the displacement or angulation in this particular fracture. So we get a lateral angulation in this type of fracture. इसमें the angulation is further increased. Why? Because of the normal tendency of the patient to keep his limb towards the side of the chest. So it ultimately causes adduction of the distal fragment and increases the deformity. So we have discussed about the displacement or the angulation in this specific type of fracture. Now moving on, what is primarily essential about this fracture is the radial nerve that is passing through. So radial nerve that is originating from the posterior cord of the brachial plexus, it travels along the distal part of the humerus, and if due to trauma or some sort of iatrogenic injury due to the surgeon due to plate adhesions, we can injure the radial nerve. So how does a patient who gets a radial nerve injury presents to us? We get a wrist drop. Since the radial nerve supplies the extensor muscles of the forearm, we get a wrist drop. Okay. So now the question arises, why some amount of displacement or angulation is acceptable? The primary reason being, proximally we have shoulder joint, that is a multi-axial joint. So even if there's some sort of decrease in the range of motion due to malunion, it is compensated for. The second reason being is, in lower limb, if we get some sort of shortening, the patient presents with limp, whereas in upper limb, it goes unnoticed. The third and the final reason is, we have thick muscles present over the upper limb, so the prominence or the malunion is not so prominent. So what are the treatment modalities for shaft of humerus fractures with us? We have the U slab, here which the extent of the plaster goes from, it starts from on the side of the neck, extends downwards towards the lateral outer aspect of the arm and towards the armpit. So this is a U slab. Similarly, we have a hanging cast. We use primarily for distal 1/3 of the shaft of humerus fractures. Again, this is an external fixator that is being used. We often use it for open injuries where we have to wait for the tissues to heal so we can ultimately proceed with the definitive management, plating, nailing, whatever. And finally, this is the intermedullary interlocking nail, IMILN for humerus. Again, this is an example of a plating for the shaft of humerus fractures. What the surgeon has to be most careful about is about the radial nerve. If it is have to protect it, we have to explore the radial nerve and have to protect it because it comes in the way. And often there are chances that a surgeon might damage the radial nerve, might even some sort of compression or some sort of neuropraxia may arise post surgically. So we have to even counsel the patient with regards to that. And moving on, we have a modified Jones transfer. That is a very commonly asked questions in NEET exam as well as AIMS exam. So here basically, since the extensor muscles of the forearm, they are not working anymore, we have to proceed with the tendon transfers. So the muscles which are not working are ECRB, that is the extensor carpi radialis brevis, extensor digitorum, extensor pollicis longus. So our ECRB, we have PT, that is the pronator teres. For ED, we have the FCU, that is the flexor carpi ulnaris. And for EPL, we have the palmaris longus. So it is very tough to memorize like this. So there's a simple mnemonic for this. Big doctors play tennis, football, and polo. Okay, so big doctors play tennis, football, and polo. This is the modified Jones transfer, and that's pretty much it for the first upper limb topic that we are supposed to discuss, and we'll discuss the further in subsequent lectures. So that's pretty much for it.